This is my external jugular vein cannulation OCSE. We do this when we need to gain IV access. Fuck's sakes! Okay. Ready?
Yep.
So this is my external jugular vein cannulation OCSE. We do an EJV when we cannot gain IV access anywhere else in the body. Also when a patient is incredibly unwell and we need to put in high volume of fluid through a large vein. So before we do anything, we need to gain consent from our patient. So Doug, is it okay if I pop a small line into your neck?
Yep, that's fine.
Cool, and if a patient is unconscious, then consent is implied. So we need to check off our gear. So I need to make sure I've got gloves, I've got my safety glasses, I've got my sharps container, I've got my Ticaderm, I've got my alcohol swipe, I've got my my gauze, I've got my cannula, which is a 22 gauge, but we generally on the road we use a 14 to 16 gauge needle. We also have our syringe, our drawing up needle, our lure plug, and our 2 salines. So we need to drug check our salines. So sodium chloride 0.9%, 10 ml, and it expires August 2019, and I'll get my offsider to check that.
Sodium chloride 0.9%, August 2019.
Cool. And I also have to check the PosiFlush. So this is a PosiFlush, 0.9% sodium chloride, 10 ml, and it expires 2020.
Cool. So you've got PosiFlush, 0.9% sodium chloride, expires November 2020.
Cool. So now we will tilt our patient's head to the side so we can get a clearer view of the vein. There we go. So now I will clean the area to make sure that where we are cannulating is completely sterile. So we do that in circular motions. And so now we need to attach, while that's drying, we need to attach the cannula to a syringe that has 5 ml of saline in it. And we do this with a drawing up needle. 5 ml. Cool. We need to make sure we maintain sterility, getting all the air out, and we do this to make sure that there are no opportunities for an air embolus to form. So we stick the drawing up needle straight into the sharps. So we've got that ready, and we attach the cannula to that. Cool. And so how we get a jugular vein to present itself to us is by either the patient bearing down, by them lifting their legs up, or by us pressing on their vein closest to their clavicle, and in this instance we will do that. So now what I'm going to do is I'm going to warn my patient that I'm going to insert a cannula. So Doug, just a small sharp scratch, so sharps out everyone. I'm going to traction, tampen out the vein, and a C grip, going to go down at a 15 to 20 degree angle into the vein. Go. Aspirate to make sure that we have flashback. Yep, we have flashback. And so now I'm going to flatten and insert the cannula with my 2 fingers. Go. Cool. So now I'm going to tampen out the vein, pull out the needle straight to the sharps. There we go. I'm going to apply the lure plug, secure it in place, and I'm going to flush the vein. And so we'll put 5 ml in. And so, so 5 ml just to make sure that we do not get any infiltration. So there's nothing, no leakage or anything like that. Cool. And so we have to make sure that a risk involved is that we can have a plastic embolus go into the vein. So we do that by only using a needle once. And we also need to make sure that we do not have any opportunity for a pneumothorax to form. And so we do this by placing our cannula further up the neck. So now I need to secure my my cannula. And do this with the Ticaderm. So there we go. So I need to make sure that's off. Pop this so I can see where I've put the needle into the secure it. There we go. Pop this there, and I note down the date, the time, the location of the needle, the size needle that we use, and we are good to go.